Alright. Good evening. Selamat datang semua. Saya ucapkan kepada semua participants, non-quorum dan quorum members as well. Dan terutamanya kepada Dr. Malwinder. Welcome, Doctor. For those
Thank
yang
you.
for those yang undergo treatment di Pantai Hospital, I believe you are familiar with Dr. Malwinder. But for those who don't, you can always Google. You can find him on TikTok, the oncologist. I believe the one and only. So if you type the oncologist, correct, doctor? If you type oncologist, you can see him. All right. So without further ado, I would like to invite Dr. Malwinder to share our topic today, the latest treatment and latest trials for colorectal cancer patients. And I believe this session would be beneficial not only for the newly diagnosed patients, but also for those who are seeking for the second opinion, as well as those who are undergoing the treatment. And the floor is yours. Silakan, Doctor.
Okay. Hi. Okay, can you see my slides?
Yes.
Okay. Okay. Is it moving?
Yes.
Okay. So hi. Yes. My name is Malwinder Singh. So I'm a clinical oncologist in Pantai Hospital Kuala Lumpur. I'm a resident there, and I also practice in Pantai Hospital Klang also. Okay, so I was given the task today to talk about latest advancement in colorectal cancer, latest clinical trial semua. So in oncology, right, the fascinating thing is actually every couple of months there's always something new coming up. And when the things are too new, kadang-kadang we will not implement immediately because we want to see how is the progress of the evidence, how the patient is responding and all. So sometimes we wait and see first, let other people try. If it's good, then we'll carry on with the treatment. Now in cancer, right, for the endpoint of the treatment might be different between an oncologist, between a patient, between a surgeon also. Okay, kebanyakannya always kita tak nak cancer datang balik. That's number one, which we call progression-free survival. Second thing is kita nak extend your life, which is overall survival. That is the main two things what we want in any clinical trial. Then the rest is sometimes we look at like response rate, how much the tumor shrink, and then toxicity, quality of life. So there are many endpoints in cancer. So one thing what I've learned couple of being an oncologist is sama pun, semua patient berbeza. So everybody has their own unique features, their own unique characteristic, their own biology of cancer. So treatment is always personalized. Nowadays, we don't treat cancer patient the same. We always do individual therapy, personalized medicine. So you can have 10 colorectal cancer patient, but all 10 will have different treatments. Okay. So my talk for today, I will divide it into what are the new changes in screening and what are the new changes in stage 1, stage 2, stage 3, and stage 4. Okay, so traditionally, when you want to go for a cancer screening, you always will go for like a colonoscopy where they do a scope for you. Sometimes they couple up together with OGDS also to scope the upper part to see whether there's any stomach masses stomach masses or not. Okay, most private centers straight away lompat pergi buat colonoscopy, but there's always some chances like if you go to a clinic kesihatan or some screening centers, you can actually check your stool. You can do the fecal occult blood test. So first symptoms normally when a patient has colorectal cancer is always bleeding. So the bleeding can be microscopic. Microscopic means you tak boleh nampak dengan mata kasar. Ini kena tengok mikroskop baru je boleh nampak. And then you have macroscopic, which you can see with your naked eyes, like your toilet bowl is stained with blood, or when you actually see blood on your underwear and all. Okay, so one of the screening tool is kita check the microscopic blood in your stool. So just take your stool, put it up inside the kit, like your COVID-19 kit, and then it will show whether it's positive or negative. Kalau positive, then they'll send you for a colonoscope. Okay, so in our Malaysian punya guideline, it is recommended, this is for normal population with normal risk, stool occult blood, once you hit 50 and above, do it every year. Colonoscopy, once you hit 50 and above, you do it every 10 years once for a normal risk population. But if you do a scope, you find macam ada polyp or there's something wrong, then probably the surgeon will tell you to scope more frequent, maybe 2 years once or 3 years once, depending on the case. Okay. And flexible sigmoidoscopy, I think hardly anyone does it anymore nowadays. Sebab that one just scope until the sigmoid colon saja. It doesn't scope all the way through the whole colon until your appendix semua. It's just maybe 1/4 of your colon only. So I think not many people do flexible sigmoidoscopy for screening anymore. CT colonogram or CT colonoscopy is also one common thing where people swallow the capsule and then they just go for a scan. You can actually see what is going on inside your bowel lining and all. Tapi I think in Malaysia, as far as I know, there is no centers who practice this lah. Most of it still go for a colonoscopy. Okay, so this is standard. Now, what I have seen in my clinical practice, and if you look at international guidelines, there are some guidelines which actually mention once you hit 40 or 45 and above, you should go for a screening already. Because I have seen my youngest patient having a colon cancer at the age of 28, and it's not a genetically linked cancer at all also. So we are seeing cancers at a younger age. So for me, once you hit 40, 45, just go for a colonoscope. Okay, now this is something new in cancer. So if some patients have like stage 4 cancer, I'm sure the oncologist would have discussed with you to do a next generation sequencing where you take the tissue and then you go and check all the mutation to see what drug works best. So this is a same thing like a next generation sequencing, but it is actually using your blood. So what happens is when a cancer starts to develop, okay, mula-mula the cancer will be very small, microscopic. Then it grows at a slow pace. The moment it hits a certain momentum, that's when it grows very fast and become macroscopic. Okay, so macroscopic you can actually cuma tengok dalam you punya macam colonoscope or from your CT scan, you boleh nampak benda-benda besar, macroscopic. But microscopic, there is no way to see because you cannot see with the naked eye. Tapi you can actually see in your blood test itself. So kalau you ada cancer from katakanlah for example colon, which is spreading around your blood vessel, is going around, probably is ronda-ronda whether you want to go to the lung, whether you want to go to the bone, tapi dia tak buat decision lagi. So it's just circulating inside your blood. Okay, so you withdraw your blood, you can actually see the circulating tumor DNA. So this is even before it is macroscopy, before you can actually see on any scans or scope. Okay, so it is not widely practiced yet, but it is coming up very, very soon. I think in Singapore, they're already doing it quite a bit. I think it's already inside their Medicare or their MediSave punya program. So in Malaysia, there are some centers who are actually doing it, and depends what panel you choose. You can actually screen specific for certain kind of cancer. Like the smallest panel I've seen, you can screen for five cancers, like your breast, colon, stomach, I think leukemia, lymphoma. If you choose a bigger panel, you can screen roughly about 20 different cancers also. Okay, so this is actually a chart which shows how a cancer actually progressed. Okay, you look at this line, this horizontal line ni kan, you can actually only see when the tumor is by imaging, which means macroscopy. Either you do a X-ray, CT scan, MRI, or a PET scan, then you can see on imaging. And this line is actually when it is still detected in your blood, circulating tumor DNA. But even for circulating tumor DNA, you must reach a certain threshold to detect. If it's very, very low, you still cannot detect. So how a cancer starts, this is the cancer. It starts from here, it grows slowly, you won't detect anywhere, patient very asymptomatic, very well. Then the moment you reach here, you can actually detect from your blood test. Then it continues to progress, and then when it's already reaching a certain momentum, a certain size, then only you detect by your imaging. Then when you detect by your imaging, that's when you start having a lot of symptoms. So that's when you go and see a doctor. Then the doctor will decide what to do next. So circulating tumor DNA is to detect at this phase. Okay. Now, you cannot rely 100% on circulating tumor DNA because it is still something very, very new. Okay, so if you do a circulating tumor DNA, we still encourage you to still go for your regular screening, like your breast cancer, mammogram, ultrasound, colon cancer, you do your colonoscope still. And then lung cancer, you still do your low dose CT scan. This is just something to add on, but you cannot rely solely on it. The technology is still being developed. It is not very, very accurate yet. Okay, so even you look at the guidelines, anyone recommend this will definitely still ask you to go for a normal screening. Okay, so that is circulating tumor DNA. So some patients who actually don't want to go for cancer screening and all, then they just want to take blood, they can actually opt on this. Okay, but we still recommend them to do a normal screening coupled with this. Now, the problem lies is if you detect a circulating tumor DNA in your cell, in your report, okay, the problem is you do not know what cancer it is, number one. Okay, because circulating tumor DNA will not tell you this is colon cancer, lung cancer, or anything. It just says that you have cancer cells in your body, but it hasn't developed to what cancer cells. Okay, so you do not know what cancer it is. And then you can't do surgery because it's so small, it's circulating inside your blood. You can't do any chemo or any targeted therapy because you do not know what is the cell type of it yet. So that's one of the downfall of the circulating tumor DNA. So that's why it's not widely used right now. But what it has helped us is, if say you are circulating tumor DNA, so rather than probably you go like regularly or screening 1 year once or like 10 years once, you might do it a little bit more frequent because you already have cancer cells in your body. So instead of going like 10 year scope, maybe you go like 2 year scope or 5 year scope. There's no guideline to say what to do if your circulating tumor DNA is positive. So this is still in development. Okay, another blood test is CEA. Okay, so a lot of patients will actually come and tell me that they have cancer, but their CEA is normal because CEA is never used as a screening tool. I know a lot of people, a lot of centers will, even Pantai also still put it under their general screening where you do a tumor marker for male, for female. The only tumor marker you can use as a screening is only PSA, prostate specific antigen. Because CEA has very, very low specificity and sensitivity to detect cancer cells, okay, and it also can be raised in benign condition, like if you're a smoker, it can still go up, okay, and even for a stage 4 cancer patient, your CEA can be normal. So a lot of patients will say, I just did blood test 3 months ago, everything looks normal, but now I come with stage 4 cancer. Why? Because CEA, from what I've seen, probably the sensitivity specificity is only about 15%. You will miss 85% of cancer if you just rely solely on CEA. And CEA normally, for us as an oncologist, we use it as a treatment response. So if someone comes with a very high CEA, when I give some treatment, I see the CEA going down, I know it is responding. So I can push my scan later on a little bit. Instead of doing every 2 months, 3 months scan, maybe I can do 4 months to 6 months scan. But if you say CEA is normal, then I do more frequent scans to actually see the response of the tumor. Okay, so that is actually screening. Okay, so now I move to stage 1 and stage 2. So this is something very new. I think probably it just got approved last year, and this is FDA approved. Okay, so what I talked just now about circulating tumor DNA for screening, but now what we do is circulating tumor DNA to check for minimal residual disease. Okay, so what is minimal residual disease? I'll explain in a while. But what you can actually see in your blood test, if you do right, and you send for this, what we call a liquid biopsy, you can actually see all these different cell types. Your macrophage, RBC, normal cell, tumor cell, circulating tumor DNA, and all. So what we are interested is the circulating tumor DNA. Okay, so why do patients actually develop cancer recurrence? Okay, so for example, if a patient has a cancer cells right now, you have a 3 centimeter mass, the surgeon go and remove the 3 centimeter mass. You do a PET scan, also 3 centimeter mass, you remove by surgery. Now, by looking at the pathology, the biopsy report, or even the surgical report, you will see whether that these cancers are actually a good biology or a bad biology. If a bad biology, you know there's higher risk of cancer recurring back again. How we know there's higher risk of cancer recurring back again? Because there's always microscopic cells left behind during surgery. If you have a good biology, the risk of microscopic cells is lesser. If you have a bad biology, risk of microscopic cell is higher. So that's one of the reasons why after surgery, some doctors will actually ask you to do some chemo and all. So how do we detect these microscopic cells? Is by doing this blood test with circulating tumor DNA. And this term is called minimal residual disease, which means before you do surgery, you take your blood. Say, for example, you take your blood, okay, you got 10% value. Then you go and do surgery. By the time you do surgery, by right, it should drop to 0%. But if you still see like 5% value or 3% value, then that means it is positive. You still have minimal residual disease. Now, whether this minimal residual disease, okay, will actually grow to cancer or it will not grow to cancer, this will only time can tell us. Okay, because sometimes if your body is strong, your immunity is strong, you can actually kill very early cancer cells also. Okay, so there are some studies right now being done. If after surgery you go and do your minimal residual disease test, if it is still high, they will offer you chemo to kill off all the microscopic cells. But it is not widely established yet. FDA has only approved this to be used as a treatment monitoring tool, but it has not been approved to actually give chemo if your MRD is positive. Okay, yeah, so yeah, this is one of the chart which I wanted to show is when you have cancer cells, you remove your cancer cells, and then whatever cancer cells left behind, there are always stem cells in the cancer. Cancer also has its stem cells. So from that cancer stem cells, it will multiply and actually grow back and become a new cancer. Then you have a cancer recurrence. So back to this chart. Okay, so just now you have normal, a cancer cell which is very early. It grows and then you get detected by ctDNA, or if you don't do ctDNA, then you grow big, you detect by imaging. Then patients will have some symptoms, okay, and then depending on the case, the doctor oncologist will discuss with the surgeons and all, see whether we want to give you any neoadjuvant therapy or straight away go for surgery. So surgery is definitely, you need to do surgery if you want to talk about cure. Neoadjuvant therapy is whatever therapy we give before surgery. It can be chemo, it can be radiotherapy, depending on the location of tumor. Adjuvant therapy is what we give after surgery. Okay, usually can be chemo, can also be radiotherapy also. Okay, so here you have macroscopic disease, okay, because it's above your imaging line. So surgeon go and do operation, remove this tumor. Okay, by right, your cancer cells should drop down to normal. Okay, but sometimes it doesn't drop down to normal. You still have some value here. Okay, which means your minimal residual disease is positive. It didn't go down to normal. So if it is positive, it gives you at a higher risk of cancer recurrence. And this is studies proven that the cancer will come back early and the survival will be shorter compared to someone who actually have minimal residual disease 0. Okay. Now, minimal residual disease, when you want to do this blood test, you must have a baseline. So a baseline is always before surgery. If you do surgery already and then you want to do minimal residual disease, you can still do, but it won't be very, very accurate. Okay, and this minimal residual disease test, there's a frequency where you do. Normally it's like before surgery, then after surgery, then 3 months, every 3 months you do. As long your ctDNA is coming down, that is good. If your ctDNA is going up, then it's bad. So if you have a very high MRD value after surgery, so normally like after surgery, maybe we do like 3 months follow-up, 6 months CT scan. So if you have an increased MRD, we will always do an earlier scan. Do earlier scans, do an earlier follow-up, just to detect whether the cancer is coming back early or not. Okay, so MRD is actually something new. It's already widely practiced. The cost of the blood test, I think for 2 blood tests, it costs about 4,000 ringgit. Okay, next in stage 1, stage 2 is called MSI, microsatellite instability. So sometimes when you have early cancer, if you look at your report, right, you see like doctor mentioned that it's Duke's B cancer, which means you have stage 2 cancer, but you do not have any lymph nodes involvement. Okay, so stage 1, normally when you do surgery, I would say probably 99.99% they won't offer you any chemo or any treatment after surgery because it's a very good prognosis disease. It's Duke's A. When you fall to stage 2, that's where the things get a little bit blur. If you have high risk features, okay, high risk features means like when you do your surgery and you see on the pathology report, like your grading is poor, and then you have lymphovascular infiltration, perineural invasion. These are all just terms which we actually see in the report to see whether it is high risk cancer or low risk cancer. Those days, if it is high risk cancer, we will offer chemo. If say low risk, then we will not offer chemo, just do observation. Okay, but nowadays, what you can do is to do this MSI test. So this MSI test is actually to check 4 genes inside your colon cancer, and every colon cancer patient will have these 4 genes inside. Okay, if everything is normal, there's no mutation at all, then we call it no MSI. It can be MSI stable or MSI low. But if we have one mutation, we call it MSI high, microsatellite unstable. Okay. There's 2 functions when you do MSI test in a colorectal cancer patient. Actually, three functions. Okay, number one is actually to see whether this is a genetically linked cancer or not. Okay, number two, you use it for stage 2 to decide whether you need to do chemo or no chemo. Number three, you use it in stage 4 disease to see whether you're going to need immuno or you do not need immunotherapy. Okay, so now I'm talking about stage 1, stage 2, where you can do MSI test, number one, in any stage to determine whether this is actually a genetically linked or not. If it is MSI high, there is always 3 to 5% that this you are actually associated with Lynch syndrome. So then you get your family members to go for screening also. Okay, if your MSI low or no MSI, MSS, that means this is 85% high chance that this is actually just sporadic. That means it happened by itself, not related to genetic at all. Okay, and for stage 2 also, if you actually have MSI high, you do not need chemo. It's a good cancer. Although you have all the risk factor, but your MSI is high, very good, no need to do chemo. If you're MSS, then we will discuss about chemo, whether you're going to need chemo IV or you're going to need chemo oral. So this is always a discussion between the oncologist and the patient, see what's the patient's preference. Okay, so that is about stage 1 and stage 2. Now I move to stage 3. Nothing much exciting in stage 3. Only thing, this is actually something which was released in 2018, I think, 2018 or 2019, but still until now, there's not much consensus. So stage 3 is a very unique area where there's always, normally when you talk about colorectal cancer, we always give like 6 months treatment, 6 months of chemo, whether it's going to be FOLFOX regime every 2 weeks or CAPOX regime every 3 weeks. So depend which one the patient prefers. So there is studies to say that, okay, sometimes do 3 months chemo is enough. We de-escalate rather than giving 6 months of chemo. So if you're looking at clinical trials, what have been shown so far, okay, if you're talking like your stage 3, you are low risk, you can do 3 months of just CAPOX. In Malaysia, we call it Xelox. Okay, but if you're using FOLFOX chemo, when you use 3 months versus 6 months, it is not clinically proven. Okay, so some people still give 3 months, some people still give 6 months. If you're high risk, 3 to 6 months, not proven. But if you are high risk and you're using FOLFOX, 6 months, 3 months is definitely inferior to 6 months. So you have to use 6 months. So this 3 months, 6 months has been dangling for many, many years, depending on the discussion with the patient, whether we want to use 3 months or 6 months. Even this is the guideline by NCCN. They mentioned 3 to 6 months, 3 to 6 months. Okay, but bear in mind, this particular trial, we do not have any Asian data. The data is purely on Caucasian population. So we are extrapolating it to our Malaysian population. If you're high risk, definitely for me and most oncologists, you go for 6 months. If you're low risk, then you just go for 3 months. Okay, so now I talk a little bit about stage 4. So in stage 4, there is a lot of changes, and any apa-apa pertukaran treatment pun kan, apa-apa progress lalu is always berlaku pada stage 4 punya cancer, because stage 4 punya cancer is actually very, very common in our Malaysian population, and a lot of clinical trials always start in stage 4 and then they get a very good evidence, then they move to stage 3, stage 2, stage 1 macam tu. Okay, so in stage 4, we have to divide the colon between right side and left side. Okay, because this is important in terms of prognosis, whether it's aggressive cancer, and also in terms of your treatment. Okay, now when your colon, normally you have cecum, you divide it into few parts. You have cecum, then you have ascending colon, then you have transverse colon. And then this ascending and transverse is normally called hepatic flexure carcinoma. And then when you go transverse colon, you go descending colon, this area is called splenic flexure carcinoma. Okay, and then you have sigmoid colon, rectum, and you have anus. Okay, any cancer which starts from your cecum up to the end of your transverse colon, it is called right-sided tumor. The moment it is descending colon, that is left-sided tumor. Okay, so this is actually important for us because if you are a right-sided tumor, okay, the overall outcome is actually poorer. A left-sided tumor patient live longer than a right-sided tumor patient. Okay, because right-sided tumor always detected at an early stage, always detected with a very large tumor. Always we have a mucinous kind of adenocarcinoma. Mucinous kind adenocarcinoma is a poor prognosis compared to just a normal carcinoma. Okay, and for right-sided tumor, most of them actually has very little response to EGFR therapy. EGFR therapy is like when you do your, I'll talk about it next, when you do your next generation sequencing, you do your biopsy to see whether your EGFR mutation is wild type or mutated. If it's wild type, you can go for targeted therapy. So even for a right-sided tumor, if your NGS actually shows that you will be sensitive to an anti-EGFR drug, it might not work well for a right-sided tumor. But for a left-sided, yes, you will work well with anti-EGFR. So right-sided tumor, normally we will give an anti-VEGF inhibitor like bevacizumab, ramucirumab, aflibercept. So those will work well on this part. But the caveat is if you want a tumor shrinkage, if the tumor is too big, the surgeon want it to shrink fast, or patient is very symptomatic, you want to shrink fast. There's a lot of clinical trial to say if you have a targetable mutation, go for it. So even you have right-sided tumor and you are EGFR wild type, you can use a targeted therapy called cetuximab or panitumumab. But although it's right side, you want fast tumor shrinkage, you just go on with panitumumab or cetuximab. It will shrink faster. But in terms of survival, of course, it's much more inferior compared to using bevacizumab or ramucirumab. Okay, so that is right side, left side. The next is what I always like to talk about. This is about next generation sequencing, where we actually take your tumor tissue, and from your tumor tissue, we will send to the lab. The lab will check all the mutation which is available in your cancer, depending what panel you choose. Like a smaller panel will check about 50 genes, a bigger panel can check up to 1,000 genes to see what mutation is positive. Okay, this can be done on the tissue and can also be done on your blood sample. Of course, tissue is better than blood sample. Okay, so you take your blood or your tissue, you send it to the lab, they do the DNA fragmentation, the library preparation, everything. Then they do your sequencing, they put it in the machine, then they will check all the DNA, what RNA, whatever is positive. Then there's a global library to actually see what mutation positive, what drug works best. So this whole process at least will take about 7 to 10 working days. Because those days we used to send it overseas, but nowadays we have local in-house lab in Malaysia to do it. So normally for not early, first time you come to see a doctor, an oncologist, you have colon cancer stage 4, normally we will always order a small panel because the common genes will always be positive. There's no point first time you come, you order 1,000 gene panels because you're going to check so many different weird mutation and it's going to be very costly. But most of us know based on clinical wise, most of the time it's always the common mutation will be positive. The bigger panel we tend to use when you have failed multiple lines of treatment, where there's not many treatment left, then you go for a bigger panel to find all the mutations which is available. Now, the problem with some of these mutations is some of the drugs are not available in Malaysia. So when it's not available in Malaysia, we need to do import permit to bring the drugs in, which will roughly take about 3 weeks to 1 month, depending on where you're practicing. So from your blood test or even from your tissue sample, we will check, these are common genes what we check. So normally I always just do the 50 genes panel, it costs about 2,000 ringgit. So you can know all these mutation, whatever is positive, you have at least about 2-3 drugs to target it. Some mutation are positive, but you do not have a drug yet because it's not developed by scientists yet. Okay, so this is from NCCN again also. So if you are stage 4, you have, we call it biomarker directed therapy. So we check if you have BRAF positive, then you go for this kind of treatment. If you have HER2 positive, you go for this kind of treatment. If you are KRAS G12C, you go for this kind of treatment. NTRK, there's a specific treatment. RET, you have a specific treatment. Okay, so some of it you might need to combine with chemotherapy. Like if you're KRAS, then you combine with some chemotherapy. Some of it you just take it by itself. You do not need to combine with chemo. So this one is an ever-changing field. Every now and then there's a new mutation. Every now and then there's a new drugs coming up. And if you want the best response, sometimes we do need combination drugs. We cannot just rely on one drug or 2 drugs to work best. Okay, this is a very big story which I think happened about 2 years ago, where there were, I think, 12 participants in the clinical trial. All of them went for this one drug and all 12 tumor disappeared. Okay. So this is actually, it went viral everywhere and actually everyone was very excited. Okay, because what happened was all these patients actually had MSI high in their tumor. So this is the third reason why I do MSI, specifically for a stage 4 cancer patient, where you actually take your tissue, you send it to the lab to see the MSI status. If your MSI high in a stage 4 cancer, straight away you can just do immunotherapy. You do not need to do chemo, no need to do targeted therapy. Your response is very, very great. Yeah, and it's a very durable response on top of it. But the problem is to get an MSI high in a Malaysian or even Asian population is less than 5%. Not many patients has MSI high. So if you have MSI high, that's actually a very good cancer. You live longer and you also have a good drug like immunotherapy to use for it. Okay, yep. So this is the same thing. MSI high for stage 4 colorectal cancer. You just need immunotherapy. You do not need chemotherapy. Okay, so that is all about colon cancer. So I'll just talk a little bit about rectal cancer now. Actually, this is my last slide. So rectal cancer is a little bit unique because rectal cancer, the drainage and how the cancer spread is always locally. Colorectal cancer, colon cancer tend to spread systemically. That means it goes to lymph node, it goes to your liver, your lung, your bone. Higher chances compared to rectal cancer. Rectal cancer like to happen local. Okay, so rectal cancer, those days, before I was an oncologist also, people normally straight away go for surgery. Go surgery and then after that they give chemo. Then down the line, they found out that rectal cancer behave a little bit different than colon cancer. So then radiation came into the picture because radiation is a local therapy. Okay, so then after that, they do surgery and then they give radiation and then they give chemo. So then scientists started doing a lot of mixture here and there, whether they do radiotherapy before, radiotherapy after, chemo before, chemo after. So up to probably 3, 4 years ago, they were normally doing radiotherapy first and then surgery and then followed by chemo. But lately, because of these two trials, which actually changed the landscape a little bit, okay, where they are actually combining a shorter fraction of radiotherapy rather than the long fraction of radiotherapy, and then they actually add on chemo on top of it, then you go for surgery. It gives a better outcome compared to doing a long course radiotherapy, surgery, and then chemo. Now, why is it like this? It's because of the logic behind the rectal cancer way of how the cancer spread. Rectal cancer is a local disease which tend to spread locally, tend to occur locally also. So that's why they put in the radiation first. So they give a shorter radiation, but they also realize rectal cancer tend to go to the lymph nodes and also tend to spread. So then they give chemo to kill all the microscopic disease. One of the other reasons why we give radiotherapy before surgery is actually to shrink the tumor also. Because rectal cancer, tumor sometimes can be very big. Sometimes it's already at your sphincter, then you might end up by doing an APR and you need to wear a stoma bag lifelong. But when you do like radiation, you can try to shrink the tumor, try to actually bring it away from the sphincter, try to save your anus so that you can actually don't end up with an APR and a stoma. So that's another reason why we do radiation and chemo before surgery for rectal cancer. So once you already kill the local disease, once you already kill the systemic microscopic disease, then you definitely need to go for surgery because you need to remove the whole tumor chunk. Then you can talk about cure. In cancer, if you can go for surgery, remove everything nicely, that's the only way for cure. Even if you leave a little bit cancer cell behind, radiotherapy, chemotherapy is not going to kill it as efficiently as surgery. Okay, that's all for my presentation.
Wow, thank you, doctor. I've been actually, to be honest, I've been waiting for the rectal cancer part because I'm a rectal cancer patient and you give a very clear picture of how my treatment was going on. Now I understand the steps. It makes sense now. It makes sense now. Thank you so
Okay.
much. Can we open the floor for the questions? Any question? Feel free to unmute.
Sorry if it's too scientific. I try to make it as simple as possible.
Honestly, I enjoy it. It makes sense. If there's no question, I have a question, and please, I'm sorry if this question sounds silly. But I wonder if those clinical trials that you mentioned, they only available in the private hospital, or is it are they available in the government hospital as well?
Okay. Actually, in Malaysia, right, we are one of the blessed countries where a lot of sponsors tend to do clinical trials in Malaysia. One is because we are cheap compared to other countries, and we have the patient population. Now, clinical trials, majority is done in a government center, but there are some private center which very, very such as like Pantai KL, Subang, they are very active to do clinical trials. But if you're looking like a government center, HKL, IKN, those are the common ones. But HPP, Sarawak, Penang, Sabah, all actually have an active clinical trial unit. Now, for any cancer patient of mine, of anybody also, I always tell them there's always a website in our Malaysian Oncological Society website. So there is a column there for clinical trials. It is updated every 3 months actually. So if any like different cancer or even colorectal cancer, if you fail any lines of treatment or even you want to find out more about clinical trial, you can actually just go to the website. It's open to everyone. Just log in. You can actually see all the active clinical trials, and then you can actually contact them directly to see whether you are eligible for it or not. And the best thing about clinical trials, I'm a very strong advocate of clinical trials, is because you get all the new innovative treatment. And in Malaysia, particularly, majority of the center, I would say 99% of the center actually does phase 3 clinical trials, which means you get a newer drug and you have a comparator arm which uses the standard of care. So whether you fall on any arms of the treatment, you will get the standard of care plus the new drug. So clinical trials also you have many phases like phase 1, phase 2, phase 3, phase 4. Phase 3, phase 4 is very established, safety all guaranteed already, dosing all guaranteed already. It's just to see whether it's working, to see the toxicity and all in Asian population. I think Ampang and I think UM also, yeah, UM also and also Sarawak, they do phase 1, phase 2 clinical trials. That means first in humans. So those are like for very, very advanced stage patient, which has failed all kinds of treatment. Then we actually send for phase 1 clinical trials because you get a very, very new innovative drugs, but you might not know whether it works or not. But if you're a new cancer patient or even you relapse one time, two times, you're still fit, you can always go for a phase 3 clinical trials. It's widely available everywhere. But clinical trials has a very, very specific criteria to fit. If you fit into the clinical trials, then you can enter. If you like your blood test tak cantik or your mutation not ngam with the clinical trial, then high chance you cannot enter the trial.
I
Okay,
see.
so I have a question here. When do patients qualify for clinical trial? After all treatment failed? No, not really. So if you're talking about phase 1 clinical trials, yes, that is normally when everyone has failed all the treatment options available in Malaysia. Then you actually go for a phase 1 clinical trial because you get a new drug which is not been widely tested yet. But even for a brand new patient, you just diagnosed to have cancer, then you can actually just look up in the website to see whether you're eligible or not. If you're first time diagnosed, we normally call it first line. If you're second time relapse, then they call it second line. So you can actually look at the title itself. So just look there, whether you have failed or you haven't started anything, you are still eligible for a clinical trial if you fit into the criteria. And yes, clinical trials is all free of charge, whether it's in the private or in the government, everything is actually free. Only thing, and they actually pay you to enter into clinical trials. They give you some money for your transportation, for your food allowance and all. So at least you get new drugs, you get free drugs, and then you get originator drug because clinical trial hardly use generic drugs. But the only problem by doing clinical trial is actually if you develop any complications. Okay, if you develop any complications in the government sector, it is free. But if you develop complications like say you do chemo and then you have some neutropenic fever, you have to admit for some antibiotics and all. If you actually fall on the comparator arm, then probably you have to pay out of your pocket. If it is because of the investigator drug, the new drug you're trying, then it is normally covered for free. Where or which website to look for clinical trial? Malaysian Oncological Society. You can look under clinical trial there. Okay, Doc, can you please explain again about MSI? I missed the earlier talk. Okay, so MSI is actually used for me, I use it for 3 reasons. Okay. For a stage 4 cancer, number one, I do MSI test, part of their NGS, next generation sequencing, because if your MSI high, you can actually use pembrolizumab, which is actually an immunotherapy, which is FDA approved. Very little toxicity, very good drug, very durable response if your MSI high. Okay. Second reason why I use MSI high is for particularly Dukes B cancer. Stage 2 Dukes B cancer, where sometimes I do not know whether I want to give chemo or I do not want to give chemo. So I do MSI. If the MSI is high, then I will not offer chemo because that's a good cancer. If the MSI is low, MSS is stable, you couple with a few risk factors, then I'll offer the patient chemo. And then the third reason is actually you do MSI to see whether this is actually a genetically linked cancer or not. So if your MSI is high, you have chances that this is a genetically linked cancer, so you have to screen your siblings and your family members and all. If your MSI low or MSS, then this is normally sporadic, that means it happened by itself, by chance it happened in you. So that's few reasons why we do MSI testing. And MSI testing is normally done on your tumor tissue itself. MSI cost, if you're talking about IHC, there's two ways of doing MSI test. IHC is a cheaper way. The more advanced way is called PCR. Okay, but when we do both of these tests, the concordance level is about 85%. So normally in the guideline also is recommended to do IHC. So if you're doing IHC, roughly it costs about less than 1K, about 800, 900 ringgit like that. If you're doing PCR, normally it costs about 2,000. Okay, next question. Once one of the main four mutation is detected, such as KRAS, is it possible to have other mutation at the same time? Okay, that's a good question. Okay, I myself have not seen, okay, having different mutation. But if you're looking in the literature and some of my other colleagues, yes, you can have a few mutation at the same time. So one of the common mutation what people have is actually KRAS and BRAF. Okay, and then some actually has KRAS and HER2 also. Very, very rare, but it do happen. So this one all depends by pure luck. And sometimes when you already use medicine to target all these mutation, and then your cancer still grows back. So normally we will still rebiopsy, hoping that there's a new mutation which grows. Because every time when the cancer grows, a new mutation might grow. So you take a new biopsy, you get a new mutation, then they'll test and see whether there's any drugs which is suitable for that particular cancer or not. Yeah. Mm.
Is there any other question? You can unmute your audio.
Which is better? Okay. There is okay. The question is which is better, cetuximab or panitumumab? Okay. There is no head-to-head trial. Frankly speaking, a lot of new cancer drugs, right? When pharma actually create the drug, they always compare it with a standard of care. And whenever this new drug comes out, right, always comes out almost the same time. Like you're talking KRAS or HER2, the drugs which actually comes out will come out probably like 1-2 years apart. So the moment you have an evidence being published that it is better than the standard of care, no pharma will actually do a head-to-head to see between the other competitor arm because they scared that theirs might be inferior. Okay, so panitumumab, cetuximab, it has been in the market for so long. I think it's been there for like 10-15 years, but there's no head-to-head to say which is better. Both is a very valid option. A very valid option. Just depends on what is the chemo combination which you are using with it and what are the toxicities associated with it. And if you are unlucky, you have a mutation like KRAS G12C, where you may need an oral treatment like isoprostol, then you need to combine with the particular arm, like cetuximab. With panitumumab. If you use adagrasib, then you combine with cetuximab. So depends what drugs we are using, what chemo we are using, and basically patient's preference. And of course, the cost. 。 . 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 。 . 。 。 . 。 。 . 。 。 . 。
Is there any other question? You can unmute your audio.
which is more expensive? To tell you the truth, I really do not know, but I really don't know. I'm sorry, I'm not too sure, because these drugs, right, it depends on the center, which center you're practicing, how much their markups and all. But if you were to ask me, I would think cetuximab is cheaper, because cetuximab, they are still giving one cycle free upfront. Panitumumab so far no free cycles. Do you offer Zoom consultation for patients? It's called a virtual consult. Yes, Pantai do offer that. They can just contact Pantai. They can arrange for the consultation. Yes, both of the drugs are effective for stage 4, and these drugs is actually designed only for stage 4. They have actually tried to bring this drug to stage 3 to give as adjuvant treatment after surgery, but all the trials have actually failed. So cetuximab and panitumumab still remain as the stage 4 drugs, and both will work well. Thank you. Any other questions? Don't feel shy.
Hello, doctor. I'm Rosliza from Johor Bahru.
Hi.
I'm a colon cancer stage 3 survivor since 2016, and
Congrats.
I'm mine is at the beginning was diagnosed as FFP.
Okay.
I didn't undergo the chemotherapy since that the PET scans was clear, and my uncle was agree not to proceed with the chemo. Until now my surgeon done asked me to do colonoscopy annually, because on my rectum the polyp is still appear lah. Is still grow, but it was the results show that is so far is a low risk lah. It's not malignant. And
The adenoma lah.
should I sorry?
The adenoma.
Yeah.
Okay.
So is it advisable for me to the MSI test or not?
Okay. Now, FAP, right, is actually a familiar. Okay, I'm losing my memory here a little bit. FAP is familial adenomatosis polyposis, something like that. Something
Yes.
genetically linked disease lah, where you actually have a lot of polyps inside your colon. Okay.
Yes.
You have FAP, it's already a inherited disease. So you do not need to do MSI test actually, because you already know you have FAP. Okay. Now, FAP stage 3, normally we would offer chemo. Okay, but now that you say it's really like 8 years down the line, you never had any chemo and you're still surviving. Actually, that is very, very good. You never had any recurrence. Of course, in cancer, you will always find a few patients which actually never do chemo and actually still survive also. And some patients who do chemo will still have cancer recurrence also. So I really do not have answer for that, because cancer is actually a very, very unpredictable area. Some people get recurrence which they shouldn't get, but some people do not get recurrence when they should get. So good for you. You do not have any recurrence. You have FAP, just do your regular scopes. The chance of you having polyps will always be there. So regularly, you just have to check up and see whether your biopsy is changing to cancer or not lah.
Okay, thank you, doctor.
No problem. Okay, there's a question about side effects of these drugs. Actually, right, side effects for me, it ultimately depends on the patient actually. If you're actually very, very fit, of course, toxicity will be very, very low. If you are someone who's very frail, you are not so fit, toxicity might be a big issue for you. If you're talking like immunotherapy, practically it's actually very well. I do not have any patients having much problem with immunotherapy. Although there's always about less than 3% chance where it boosts your immune cells and your immune cells will start attacking your normal cells. So you might have a lot of like colitis, a lot of diarrhea, hepatitis, where you can actually become jaundice, skin reaction, where you have a lot of rashes on your body, pneumonitis, where you cough. But the chance is actually very, very low. If you're talking like targeted therapy, like panitumumab, cetuximab and all, those, the main problem is always rashes. Rashes on the face, you get all the red spots. If you're exposed to the sunlight, it gets a little bit worse. So just put sunscreen, put some steroid-based cream, take some antihistamine. It should be well controlled lah. Most side effects is always very well controlled by some additional medication, and it's always just by adjusting the dose which is suitable for a patient. All the dose what we give for a patient, right, when we start a drug, is always a Caucasian dose, and we know that Caucasian patient tolerate certain drugs better than Asian because Asian is smaller bill. So sometimes we just need to play around with the dose to find the dose which is suitable for you, which you will actually get a response, but not too low that your cancer might reoccur and you waste money by buying that drug. So it's always a balance, and everybody is different. So you need to discuss with your oncologist and see what toxicity you have, talk to the doctor, then the doctor will actually try to find some solution for you. Okay, cost of immunotherapy per cycle of immunotherapy, if you're doing it in private, will roughly cost you about 19 to 20,000. It is done every 3 weeks, and usually it is continuous. There is no cycle, but we will stop it at 2 years if you do not have any cancer recurrence. This is specifically for stage 4. But some of these drugs are actually very, very expensive. So some of the pharma companies actually, they try to help out the patient by giving patient-assisted program. Like for immunotherapy, their patient-assisted program is run by NCSM, National Cancer Society of Malaysia. So the company is called MSD. They collaborated with them. So you need to submit some papers, you go through some interviews, and then they'll give you some program. Like I have one patient who actually buy 3 cycles. They got 9 cycles free after that. So they save a lot of money actually. So there are a lot of programs in Malaysia for cancer drugs. So not all drugs are very, very expensive. Some actually have very good cancer support where they interview you, and sometimes if you fall into a very good category, you might just buy one and free 9 also. There's some drugs which is available like that. So you just talk to your doctors and see what are the best drugs available for you and what patient assisted program is available for you. Okay, is there a time span or how early to start chemo? Yes, depending on the stage. If you are talking adjuvant, that means we are still trying to cure you. We want to kill all the cancer cells. Okay. Now, if we want to kill all the cancer cells, the moment you do surgery, the best time to start chemo is going to be about 3 to 4 weeks. That's the best time to start. But that's when you get the maximum response. The moment you delay every week, your response drops down. The moment you hit 3 months, most of us will not offer you chemotherapy anymore because the benefit nobody knows. Most clinical trials involve patients less than 3 months after surgery. More than 3 months, nobody knows whether it works or not. If you're talking about stage 4 cancer, now stage 4 cancer is a little bit tricky. For me, I always tell my patient, if your tumor is smaller, it's easier to control. If your tumor is bigger, it's a little bit harder to control. The earlier you start, definitely is better for you. Okay, but there are a lot of studies to prove that. Remember, I told you in the starting of my talk, in cancer, you look at 2 things: how long I can suppress your cancer, and how long I can extend your life. Whether you start chemo now or you start chemo like 1 week, 2 weeks difference, it's not going to change your overall survival. It might just change your progression-free survival, which means I can suppress your cancer lesser if you start later because your cancer would have been a certain size. If your cancer is smaller, of course, I can suppress it longer. So for a stage 4 cancer patient, ultimately what we want is quality of life. So again, you still need to discuss with your doctor and see what is the quality of life which you want. For example, if a patient comes to me, they say, okay, doctor, I want to start treatment fast, I very kanchong, I want to kill everything, I want to get good response, then I'll start straight away. compared to someone else who's a stage 4 and come and say, doctor, next week is my daughter's wedding or my son's graduation or anything, I would like to go for that. Then I say, okay, fine, fair enough, because when you start chemo, you're going to develop all these toxicities. Delaying chemo 1-2 weeks is not going to change anything. So just go for the graduation, go for the celebration, get the quality of life, enjoy yourself, then you come back for the treatment. So just discuss with your doctor always. There's always a solution. Okay, okay, if you're talking about general cancer in the whole body, right, there is only a couple of cancer stage 4 where you can actually cure. Okay, one of it is testicular cancer, germ cell tumor. One of it, thyroid cancer also, you can actually cure a stage 4 patient. And then colon cancer with stage 4, head and neck cancer with stage 4, you can still cure also. Colorectal cancer with stage 4, you can still talk about cure. Okay, but provided you have something what we call oligometastatic disease. When we say oligometastatic disease, right, which means you have cancer which is stage 4, which has gone out of your colon, but you have very little disease. Normally, we would say less than 5 lesions. If you have less than 5 lesions, which you can actually resect later on, then yes, we can still talk about cure. For example, a patient who comes with me with a colon cancer and liver metastasis, the cancer spread to the liver. You got 1-2 bg in the liver, I can still cure you. Remove the tumor in the liver and remove the tumor in the colon, do your chemo, you will be cured. Compared to another patient where suddenly I got 10 bg in the liver, both lobes involved, that one definitely I cannot cure the disease because too many lesions already. Or for example, you only got 1 lesion in your brain or 1 lesion in your lung. You go for surgery, remove that lesion, do your chemo, we can still talk about cure. But of course, this kind of patient, the relapse rate is higher. So just do your regular monitoring for the patient. So I have patients like stage 4 colon who has liver mets, where I actually did chemo, remove the tumor, and then I gave radiation to the liver SBRT because the patient was not fit for surgery. It's already 3 years down the line. She only had chemo 8 cycles and then she's done with it, and then now she's still cured. There's no cancer recurrence. So I'm not saying everybody will go through it. This is by chance, it's always pure luck. So sometimes the cancer will come back, sometimes the cancer doesn't come back. But there's no harm trying.
Is there any other question? If no, I think we can call it a day, call it a night. I would like to thank Dr. Malwinder and all the participants for joining us tonight. I believe many of us benefit from this sharing, and I myself learn a lot. Okay, so
Thank you.
everyone, thank you everyone. Good night. God bless everyone.
Thank you, doctor. Thank you.
Thank you.